in our webinar. So first of all, I would like to invite Professor Ashok Ratan, who is a microbiologist and advisor and a mentor at the Center of Excellence for Microbiology and East Knowledge Forum of Gurugram, India, to start with his presentation. Professor Ashok Ratan, please. So, Ratan, if you can hear me, you can start with your presentation. Thank you.
Good afternoon, everybody. This is Professor Peter Hockey in Sedona Hotel when we were last in Myanmar for a WHONet workshop somewhere in 1998. Today, I'll be talking about demystifying laboratory diagnosis of SARS-CoV-2 causing COVID-19 infection. This coronavirus actually is a virus of animals, and from animals it has jumped into human, and then from human to human transmission has been extensive. This is the 7th human coronavirus. We've had 2 serious ones earlier, that is SARS in 2002 and MERS in 2012. At this moment, there's no known or approved treatment of vaccine. There's rapid spread from man to man, and diagnostic tests are playing a key role because the control strategy is test, trace, and treat, and the treatment is isolation. The virus is a single-stranded RNA virus, and it binds to the ACE2 on human. Once it binds to the ACE2 receptors in human cells by its spike protein, the spike protein is like a key which opens the door into the cell, and then the virus takes over the cell and starts multiplying inside the cell. That attracts a lot of cytokines and neutrophils and cells which can cause the damage. So there seem to be 3 stages. One is asymptomatic stage, symptomatic stage, and then late stage where the complications occur. Diagnostic tests can help identify patients who have current infection, can help identify those infected so that they can be isolated, help identify if they have suffered from previous infection in the past, can help identify if public health measures are working or not. Biomarkers can help in risk stratification between mild and severe cases. Diagnostic tests can help in development of new drugs, can identify if it is safe to go back to work, reopen office, or send children to school, can help identify effectiveness of vaccine when they become available. This virus normally causes asymptomatic infection. Large number of persons infected are asymptomatic. Symptoms appear to be more prominent in older persons, and so is the severity. The symptoms are cough and shortness of breath along with fever. If a person has fever, cough and shortness of breath, you should think of COVID in this kind of situation. Though of course what appears is that there is normally loss of taste and smell. One of the earliest symptoms is loss of taste and smell, along with fever, cough, and fatigue. And thereafter, after a week or so, a person may either recover, which normally happens, but a small percentage will have severe infection. Since the virus binds to ACE2 receptors, wherever ACE2 receptors are available, you would find the virus can cause infection. As a consequence, there are symptoms appearing in the neurological symptoms, renal symptoms, hepatic symptoms, and others, depending upon wherever the virus is available. But on autopsy, it has been noticed that though the left panel shows the spread of virus, the right panel shows where the damage occurs. So it appears that the damage is caused more by imbalance of host response rather than the virus itself. And three stages can be identified. First stage is the viral response stage, where the virus multiplies. The second stage is the pulmonary stage, because ACE2 receptors are present right from the nose to the lungs. The virus multiplies in the upper respiratory tract as well as the lower respiratory tract. But if the host response is adequate, the virus will be removed. But if inflammatory response sets in, then a person goes in for hyperinflammation stage, which is known as the cytokine storm. The lab diagnosis we will talk today is for detection of current infection, which is RT-PCR, which is the gold standard, as well as rapid antigen test, which can give results in less than 30 minutes. Along with that, the other part is to detect past infection, because many of the persons will have asymptomatic infection. In that, you can do serology, where we would look first for whether there is exposure and finally whether there's protection. Today, we'll not talk about biomarkers in my presentation. The analytes are dynamic in nature. So depending upon what stage of the infection is, you would have different values. So you should keep that in mind, that depending upon the stage of infection, biomarkers. For infection, there is normally a lag stage where this is the window stage or before symptoms appear. Normally it is 4 days. The virus is present in the respiratory tract because that is where it gets entry from, and it is spread through respiratory secretion. The virus can be found before the patient becomes symptomatic. After he becomes symptomatic, the virus is infectious for 8 days or so. Thereafter, once the recovery starts, the virus can no longer cause infection in the cell lines, but RT-PCR may be positive for weeks together. After 2 weeks or so, antibodies will develop. So in the stage when the virus is multiplying and is in high concentration, antigen detection, which is less sensitive than the other methods, would be positive. The advantage of antigen detection is that it will give you results in 30 minutes time, so that you can immediately isolate a positive person. But it has a tendency to give false negative. So when a person is positive, antigen positive, you can be sure that a person has COVID infection. But if a person is negative, you cannot be sure that the person doesn't have infection. So for that, RNA-based diagnostic test is the best, because that will give you RT-PCR is more sensitive, because the number of viruses present can be amplified manyfold so that you can detect. After 2 weeks, we should then do antibody test to get an idea of whether a person has had past infection from the virus. The since the genome of many viruses were available in the early part of the infection, that was by the 10th of January, we had full genome of many viruses. It was found that the specificity resides in the N gene or the M gene, and also in open reading frame, that is known as ORF1AB. So many PCRs have been made. Since this is an RNA virus, we would have to make RT-PCR, reverse transcriptase real-time PCR. The PCR involves 4 steps. One is collection of the respiratory secretion, the collection of the sample, which is normally collected in virus transport medium. Then there is extraction of the nucleic acid. The nucleic acid, after it has been extracted, then we do RT-PCR, real-time PCR, normally one step, so that in one tube we do both reverse transcriptase and we have polymerase, so that both RT-PCR will convert RNA into cDNA, and then cDNA will produce the PCR, and finally we can read the results. Overall, it takes about 4 hours or so from start to finish.
One-step approach and the two-step approach. In two-step RT-PCR, the first step involves the reverse transcription, or RT, of RNA by a reverse transcriptase. This reaction generates the first strand complementary DNA, or cDNA. cDNA is then transferred to a separate reaction for the same synthesis. During synthesis, DNA identified by DNA
So using the RT-PCR, we will get the amount of fluorescence crosses. The kit that we use is from Thermo Fisher, and it is known as TACPath COVID-19 combo kit because it looks for 3 antigens of COVID: open reading frame 1AB, the N gene, and the spike protein gene. Along with that, it has MS2, as MS2 is a bacteriophage, an RNA bacteriophage, which is added to all samples to act as an internal control for the isolation and extraction of RNA. At least 2 of the 3 genes must be present before we can say that the sample is positive. As you notice here, if only MS2 gene is amplified, it means it's a negative report. On the other hand, if all the 3 genes are amplified, then this will be taken as a positive report. Recently, it appears that if you do sequential testing of RT-PCR, then the CT value keeps on increasing. The lower the CT value, the higher the viral load. And after 8 days of infection, the virus cannot be isolated in cell culture. So it is no longer infective. So a patient is infective for about 8 days after appearance of symptoms. Thereafter, it is the dead RNA or fragment of RNA which may be positive in RT-PCR. So it appears that when you get all 3 positives, you want to know what is the CT value, because CT value below a threshold shows that the viral load is high and it is infectious. Thereafter, it may be only fragment of RNA which is extracted. Besides the cumbersome RT-PCR, there is also Gene Expert, which we have been using in the past for tuberculosis, which is a closed system where you put in only the sample, and in 1 hour's time, you will have an RT-PCR report for COVID positive or negative. There is also a locally available RT-PCR, which is known as TrueNAT. They both appears to work very well and are suitable for far off places where high technical staff may not be available. As I mentioned in the past, RT-PCR and antigen detection would be detected in the first week or so. And our rapid antigen has the advantage that it will give you results in 20 minutes time or less than 30 minutes. The kit insert contains all this equipment. You would additionally need PPE because the sample to be collected is respiratory and there is risk involved in collecting sample. Nasopharyngeal swab is what is collected.
Check
for rapid identification of symptomatic and asymptomatic, and if the reaction is positive, then we should isolate the person. The recommendation is that since it can give false negative, you might want to do RT-PCR for those who are symptomatic but test negative by the rapid test. It was also noticed that RT-PCR in best of situation is positive in only 80 to 90% of those whom clinicians feel are suffering from COVID infection. To increase the diagnostic yield, you need to add serology. But serology comes positive subsequently. That means after 1 or 2 weeks of infection. So serology cannot be used to control the infection, but it can be used for completing the diagnosis of the disease. There are two serologically active antigens. Nucleic capsid, which is present in large volume in the virus, is the most immunogenic. But as I had said in the past, it is the spike protein which acts as the key to open the lock of the cell and cause infection. So antibodies to spike protein are protective, while antibodies to nucleocapsid will only indicate whether you have been exposed to the virus or not. The best method, of course, is the neutralizing test. But since the neutralizing test requires the use of a live virus, it is not recommended. In India, it is not permitted to do plaque reduction neutralization test because otherwise the virus would grow in number and cause infection. So the right place for antibodies is after 2 weeks of infection. There seem to be some confusion about IgM, IgA, and IgG. And there are various reports of the dynamics. But of the 4 methods available, rapid CAR test for antibodies is not recommended, while ELISA or chemiluminescence is recommended for the method, and plaque reduction neutralization test is not advised because of the risk involved. So many commercial antibody kits are available. Abbott has kits which run on Architect, Roche on Alexis, Diasorin on Lyson, Euroimmune has ELISA, and Johnson & Johnson has Ortho. They detect IgG or pan-IgG and detect nucleocapsid or against spike. Nucleocapsid will indicate whether a person has been exposed, while antibodies to spike protein will indicate whether a person has protective antibodies or not. So if you test against nuclear capsid and look for pan antibodies, you will be able to comment upon whether a person has been exposed or not to the virus. While if you detect antibodies against the spike protein, which are IgG in nature, then you know that they are neutralizing and they are protective. We suggest, and that's what's been suggested by CDC Atlanta also, that first you do screening test. If the screening test is negative, that means the person is exposed, has not been exposed to the virus and is susceptible. If the person is positive, then you should do a confirmatory test looking for antibodies against spike protein. And if it is positive, that means the person is protected, because spike protein antibodies correlate with neutralizing antibodies in the print test. In India, a company, Thyrocare, has performed more than 1 lakh testing and find that already been exposed to the virus. In of healthcare workers, you may also want to test before surgery along with RT-PCR. Then for those who have recovered from the infection, whether their antibodies, their plasma can be used for treatment of serious diseases. Again, if you have antibodies, then you can go back to work, but personal protection like wearing mask, washing hands, and social distancing must be continued. The study from Harvard indicated that while RT-PCR is excellent for diagnosis of early infection, antibodies after 9 days play a significant role and become positive in majority of persons who have recovered after 21 days. So they can be used as a complementary test to RT-PCR. The take-home message is RT-PCR is the primary diagnostic method for SARS-CoV-2 infection. Sensitivity of RT-PCR is about 70% in the first week, but declines thereafter. Antibodies appear after 1 to 2 weeks of infection. Neutralizing antibodies are present in those who have severe infection. Animal experiments indicate that reinfection does not occur. Detection of antibodies can be used before surgery for convalescent plasma, to check for immunity or susceptibility, for surveillance as a complement to RT-PCR, and you should use chemiluminescence or ELISA. I thank you for your attention. That's all I had to say at the moment. Of course, final words I would like to say is that COVID is not only infecting persons, but it's also having implications on tuberculosis, on HIV, malaria, maternal and child health, routine immunization, non-communicable diseases, and reproductive health, as well as poverty. So we need to pay attention not only to COVID, but the opportunities lost for these infections. I thank you for your attention. Over to you, sir.
Yes, thank you, sir. Professor Ashok Ratan, and thank you for joining us in this conference, as well as giving us some information about the diagnostics and tests that you're running in India. Our next speaker will be Dr. Manoj Goel, and he is a clinician. He's a writer and head of pulmonary and critical care and sleep medicine at Fortis Memorial Research Institute, JB, and he's authored a book on bronchoscopy ICU. He'll be talking, I believe, on clinical aspects of COVID-19. But I hope that Professor Ashok Ratan will be able to join us later on in our panel discussion. So now I would like to give the floor to Dr. Manoj Goel. Dr. Manoj Goel, please.
Uh, Thank you, the expert panelists there in Myanmar. It's a great opportunity and honor for me to be associated in this meeting. India and Myanmar share a lot of traditions in common, and it's indeed a great privilege for me to be associated in this important discussion on COVID-19. So what I'm going to do is to discuss in next 20 minutes the clinical overview and management of COVID-19 infection, and also share some of my experience which I've learned over the last 6 months. And the fact is that we have come a long way in understanding of this disease. And that what is happening because of that is now, even though the pandemic is unstoppable at the moment, it's going on and on. New cases to the tune of 3 lakhs are occurring and reported all over the world. India is reporting around 60,000 cases or more per day, but definitely the mortality rate has come down because of the improved understanding of the management of this disease. So I'll start off with this slide, which was published from Italy, and it shows the case fatality rate as per the age group. And as you would see, that people who are aged less than 50 years of age, you can see the case fatality rate is less than 9%. And when it is less than 20, it's less than 0.1%. So in younger generation, younger population, it is not very fatal. It's usually mild or asymptomatic. Between the age of 50 to 60 years, the fatality rate is 2.7%. But after the age of 60 years, you can see the fatality rate can really bounce to up to 30.7%, from 10 to 30% as the age increases. And the same pattern was also shown in Chinese studies also. But what we found that in China, the mortality rate was 3%, but it was found to be around 9%. The reason is that there was more vulnerable population involved in Italy, where the elderly population was more affected as compared to China, where the younger population was affected. So that's why the elderly population is really vulnerable. And that is the most important risk factor for the development of serious disease concerned and the mortality is concerned. Now, this is the timeline of the symptoms of severe COVID-19 infection. The incubation period usually 6 days, but we know it can be from 2 days to 14 days. And the patient would develop symptoms like fever, cough, fatigue, anorexia, myalgia, and diarrhea. And these kind of symptoms would be there for about a week. And then what happens is the fever would generally come down. The symptoms of cough may come down. But then in the second week, 40% of symptomatic patients would develop some sort of respiratory complaint, especially dyspnea. It is observed that severe illness develops in 14% of symptomatic patients and critical illness develops in 5% of cases. It's the second week which really becomes very important, which is the week associated more and more complications of COVID infection. So the fever comes down, but the respiratory complications appear, and that is the time when the pneumonia really starts to become more permanent. And these patients who got a serious disease or critical disease, they have a fatality rate of 10 to 15%, which is really high. So we really have to really watch out for these kinds of patients who are suffering from severe and critical illness. Now, when a patient comes to us, we have to critically evaluate whether he needs hospitalization or he needs admission to the ICU. We have to clinically evaluate the patient, particularly with regard to the symptoms like cough, the breathlessness, the pulse oximetry, the oxygen saturation. We look for the chest X-ray abnormalities in these patients. Whenever in doubt, perform a CT scan, especially if the symptoms are out of proportion with chest X-ray findings. Look for the comorbidities, which is very, very important. And I'll be discussing about these comorbidities in a couple of slides. We look for the pneumonia on the chest X-ray imaging and on the CT scan, and look for whether the patient needs an oxygen therapy. And based on that, we decide whether we can manage this patient in the hospital or we can send this patient for home care management, where most of the patients are managed. Patient coming to the emergency department with severe respiratory failure shock. For those who are already admitted, develop worsening of their symptoms, worsening of their oxygen saturation, then they would be admitted to ICU. Now, one of the important aspects in the management of the COVID infection is to assess the risk factors of serious disease, because this is very important, and here lies the higher fatality rate or higher morbidity. So older age is a very important, I think the most important factor is age. Age more than 60 years. Patients suffer from cardiovascular disease, diabetes, chronic lung disease, cancer, cerebrovascular disease. These are vulnerable for higher risk of morbidity, mortality, and severe disease. And I would add one more risk factor, that is obesity. If the BMI is more than 40, that this is again a vulnerable population, and we must watch out for these cases as well. The chest X-ray or the radiological imaging becomes the key in the management of these cases. And the chest X-ray finding that you find in these cases would be normal in 63% of cases, especially in early stages who are asymptomatic or who got mild disease. The ground glass opacities are found in 70% of the cases. Consolidation can also be observed, but usually it is patchy. It is not the classical lobar or segmental consolidation that we find in bacterial infections. There may be coarse opacities which are sensitive to fibrosis, which appear in the later stages. And in the later stage, we can have a combination of all ground glass opacities, the patchy consolidation, the coarse opacity sensitive to fibrosis. The surgical emphysema pneumothorax is rare in these patients, but occurs in severe cases who require some sort of mechanically ventilated support, maybe non-invasive ventilation, maybe mechanical ventilation, which is invasive. But what we have found that development of barotrauma is much higher in patients who are suffering from COVID as compared to other patients who got ARDS due to any other cause. The nodules, cavities, and pleural effusion are uncommon. In fact, the cavities appear in a patient who already has got a COVID infection, COVID pneumonia, that is suggestive of superior bacterial fungal infection, like necrotizing pneumonia. The distribution of opacities is mostly peripheral. It's mostly bilateral, observed around 70% of cases, and mostly the opacities involve the lower zones, but there could be patchy scattered distribution of opacities also. They can be unilateral in 25% of the cases. And in severe cases, the whole lung may be involved, where all the segments, all the lobes can be involved, right from top to the bottom. This is the chest X-ray, which is normal, and it's the usual finding in most of the cases of COVID infection. You would have mild disease or asymptomatic disease. But the classical presentation, classical radiological presentation of COVID infection is bilateral peripheral pneumonia, which is subpleural, involving the lower zones. And you find there is sparing of the involvement of the central lung parenchyma. So this is what is a classical presentation, radiological presentation of COVID pneumonia. And this is a CT scan, which is again showing a classical findings of COVID infection, where you can see there's a ground glass opacity, bilateral ground glass opacity, which is subpleural, involving the lower zones. And what you can see, this ground glass opacity is confluent, and it has a distinct, margin from rest of the normal lung parenchyma, right? So this is quite classical of, COVID infection, and the sensitivity of the CT scan has been found to be more than 90%. We talk about the sensitivity RT-PCR, which is 70% in the early stages, but sensitivity CT scan is much higher as compared to the RT-PCR test. And why we say it's a ground glass opacity? Because you can see the Western marking through this gray opacity that you can see, a gray artifact. When the consolidation occurs, then what you find, these vascular markings disappear. They merge with the opacity, and there you generally find a air bronchogram sign. In later stage, you can see all the segments and all lobes can be involved. This is a case where you can find there is a patchy distribution. There is a patchy consolidation here. Here and there, you can find that kind of a patchy consolidation. This is a patient who has extensive bilateral pneumonia, but again, you can see there is a peripheral predominance. Then this is predominantly a unilateral consolidation, again peripheral. You find a little bit of some infiltrative lesion on the left side, on the right side, but predominantly it's a unilateral disease here in this chest X-ray. Then again, you can see here there is a patchy area of consolidation. It's more than downglassing. We got a opaque opacity where you cannot find the Western markings, and this is a patchy distribution which is there. But again, you can see it's more peripheral, and there are more in the lower zones. Then this is a bronchopneumonia kind of a picture, patient on ventilator with severe disease, where there's a distribution all over the lung. Then other case where you find, which I was talking about, a surgical emphysema was on ventilator. As you can see, he's got a surgical emphysema here. There's a pneumothorax, there's a chest tube. And these patients tend to develop recurrent pneumothorax and surgical emphysema. And generally, this would be bilateral. So we have to be very careful about the ventilator settings while managing in these patients. Then this is another patient. You can find the patchy areas of ground glassing, right? Again, more peripheral distribution, right? And as the disease progresses, they will tend to become more confluent and more distributed. Another case, CT scan, you can see the ground glass opacities, patchy areas of consolidation, peripheral. Other case where you can find this upper zone involvement, where there is a ground glass opacity in the right upper lobe. Another patient where you got a unilateral consolidation, peripheral, very little involvement on the right side. Then patchy involvement, peripheral, ground glass opacities. And one patient we found there was a solitary ground glass opacity. And you can see there is a reverse halo sign in this patient. And when later on I repeated the CT scan after 1 week, even though the patient recovered, you could find the bilateral opacities. So initially you may even find a unilateral localized involvement in some of the cases. These are patients who had a normal chest X-ray but had symptoms of cough and breathing difficulty. And in this case, we did a CT scan, and here you can see the patient got the lung involvement, patchy distribution of the opacities. You can understand the lung shows only 60% lung parenchyma. If you want to see the whole lung, then you need to do a CT scan. So in selected cases where the symptoms are out of proportion to the chest X-ray findings, a CT scan can be advised. We routinely do not do the CT scan in these patients. In the chest X-ray is classical. There is no need to do a CT scan in these patients. We do CT scan only in the later stages to look for any complications and to look for the residual changes which may require long-term treatment to prevent the fibrosis in these patients. The pathophysiology has been very well discussed by Dr. Ashok Ratan. It's a very complex phenomenon, but I'm here going to show you the COVID-19 disease cycle where the viral infection would occur, especially the vulnerable population, those who are at high risk. There will be unabated, multiplication of the virus. It will keep forming its copies, which is set off an inflammatory cascade, which will then set off a coagulation activity, which causes a prothrombotic state, and then it can again cause a sort of a supra-inflammatory state with cytokine storm, and this cycle goes on. What this cycle shows us some important facts as far as the management of the COVID infection is concerned. So what are our pathophysiological targets? We can treat the viral infection by using antiviral therapy, whatever we have got. We can treat the inflammation by using anti-inflammatory drugs like corticosteroids. We can treat the prothrombotic state by giving anti-thrombotic therapy like anticoagulants. And when there is a supra-inflammatory state, especially when there is a cytokine storm, then we can use the drugs which are acting against the cytokines like anti-IL-6 receptor antibodies or monoclonal antibodies like tocilizumab. So that's why there are various targets which we can use in the management of these cases, depending on what pathophysiological process is going on. So when we are managing these patients, we really have to identify what is the pathophysiology based on the clinical data, based on the biochemical parameters, based on the X-ray picture, CT scans, whatever. So we can have and what stage of the disease, like in early stage, there will be more of the viral infection. In the later stage of the disease, there's more of the inflammatory cascade going on. So we have to really look into the pathophysiology of these patients and try to target that pathophysiology, which is going to really determine the outcome of these patients. Now coming to the treatment, if the patient presents with mild severity, which is characterized by symptoms like fever, cough, sore throat, nasal congestion, malaise, and headache, without any evidence of breathlessness or hypoxia or shock, the oxygen saturation in these patients would be more than 95%. And if these patients do not have any comorbidities, and if we do a chest X-ray which is normal, or the involvement of the chest X-ray is less than one segment, there is no need to really investigate these patients further. We can keep them at home, put them on home quarantine, and treat them with asymptomatic management like paracetamol for their fever and cough lozenges. But they need to be monitored from symptom point of view and their oxygen saturation. So what we do, we generally advise them to monitor the symptoms, especially the chest pain, breathing difficulty, any dizziness, mental disturbances, and oxygen saturation monitoring would be required in this patient on pulse oximetry. And we advise them if their oxygen saturation decreases below 95%, then they must report to the healthcare facility. Now, if these patients with mild severity have got the comorbid disease, such as the age more than 60 years, the hypertension, diabetes, chronic lung, kidney or liver disease, or cardiovascular disease and obesity, then we investigate these patients with moderate disease and we treat them under strict medical supervision. Preferably, we would advise this patient to be admitted to the hospital because this is a vulnerable population and they can really, have a higher degree of, illness and mortality. And we definitely consider managing these patients as a moderate disease, even though the symptoms may be mild. The moderate disease is characterized by clean features of dyspnea and/or hypoxia, fever, and cough. The oxygen saturation in these patients would range between 90 to 94% room air, and the respiratory rate would be somewhere between 24 to 30 per minute. In these patients, we'll go for investigations. We'll do a detailed clinical evaluation of these patients, particularly in terms of the dyspnea, the comorbidities, the oxygen saturation. We look for their vital signs, the pulse, the blood pressure, the usual vital signs, the conscious status. We look for the oxygen saturation of these patients very, very carefully. We order a chest X-ray, and if required, we also order CT scan these patients, do a ECG. We offer them with basic labs like CBC and different count. Look for especially the absolute lymphocyte count, which would be decreased less than 1,000 in around 70 to 80% of patients who are suffering moderate to severe disease. The KFTs are generally normal in these patients. The LFTs may show mild development of the transaminases. The coagulation profile is usually normal in these patients. We do offer the inflammatory markers in these patients, especially the CRP, ferritin, and IL-6. Okay, this is ordered in these patients, but if you've got the facility, do offer the CRP, D-dimer, LDH, procalcitonin, ferritin, IL-6. And depending upon the severity of the patient, the progression of the disease, we would like to do this test and repeat this test. which may vary from 48 to 72 hours. And on individual basis, we can even repeat this test on daily basis because they can guide us as to what kind of pathophysiological state the patient is going to be and what is his likely progress. And needless to say, this patient would be admitted to the hospital. And what we do in hospital, we closely monitor their work of breathing, especially the respiratory and use of excessive muscle respiration, look for any hemodynamic stability. So a regular continuous hemodynamic monitoring would be required in this patient, and also look for their oxygen requirement and pulse oximetry. And if there is increasing work of breathing and hemodynamic stability, or there is increasing requirement and the oxygen saturation becomes less than 90%, then they would be treated as a serious disease and would be shifted to the ICU. So in moderate severity, the key element is the supplement of oxygen. We target SpO2 of 90 to 96%. I preferably try to keep oxygen saturation more than 95% because it has been observed that hypoxia in itself can lead to the inflammatory cascade. So if my oxygen requirement is not very high, I'll prefer to keep the oxygen saturation more than 95%. But yes, if the patient got a COPD or other chronic respiratory disease, then I can keep oxygen saturation maybe between 90 to 92%. But preferably I keep oxygen saturation more than 95%. Various devices that we use for oxygen supplementation are the nasal prongs, the mask, and non-rebreathing reservoir bag. Generally, an RBM would be required in patients who are in intensive care unit, and this is required, and I would shift this patient to the ICU. Dexamethasone, 6 milligram IV up to 10 days is recommended. If the oxygen requirement of the patient is increasing or the inflammatory markers are increased. So I would not use dexamethasone in all the cases of moderate severity, but if the oxygen requirement is there, which is high and it is increasing, and the inflammatory markers like CRP, BDAM, or ferritin are high, then I would use dexamethasone in these patients. Anticoagulation is the key management. I would use anticoagulation in every case of moderate severity disease, which could be prophylactic, intermittent, therapeutic. I'll talk about this a little later. And in some patients, I would also use the antivirals, which could be repurposed or investigational. Then in some cases, we do use the empirical antibiotics, especially if the high-risk patients are there, or when there is a suspected bacterial infection. But as a protocol, any case of pneumonia which is requiring oxygenation, we generally try to give them some basic antibiotics like the doxycycline or ceftriaxone. Convalescent plasma would be offered to some of the cases of moderate severity. Again, I'll talk about this a little bit later. And the antiviral drug that we prefer in these patients is remdesivir at this point of time, especially if the oxygen requirement is more than 3 liters or 4 liters. But if patients' oxygen requirement is maybe 1 to 2 liter, mild disease, sort of a disease is there, and there are not too many of the lung infiltrates on the CT scan, the chest X-ray, then I can prefer favipiravir also. But the antiviral of choice is the remdesivir. The dose is 200 milligram IV on day 1, followed by 100 milligram daily. And I give it for 5 days only. I do not generally give for 5 to 10 days, especially because the role of extended use of remdesivir is really not proven. I would consider using tocilizumab in selected cases when the patient is showing signs and symptoms of cytokine storm, and also the inflammatory markers are very high. Coming to the severe disease, which may present with severe pneumonia, ARDS, and shock. The severe pneumonia is characterized by severe dyspnea, hypoxia, fever, cough. The hallmark of severe disease, the oxygen saturation would be less than 90% on room air. So that would be the hallmark of a severe disease or severe pneumonia. And a patient who presents to me with oxygen saturation less than 90% considered severe disease, I'd like to keep him under strict observation and prefer them to be admitted in the ICU. The respirator in these patients would generally be more than 30 per minute. And of course, the ARDS shock is there, and the patient would be admitted in the ICU. The investigation protocol would be the same as in a moderate disease, but here I may have to repeat these investigations more frequently, maybe on a daily basis in severe disease to look for how the disease is progressing. And if it is progressing, then we can decide what interventions we need to offer to these patients. And many of these patients would require respiratory support with high flow oxygen, HFNC, NIV, mechanical ventilation, depending on the severity of oxygen requirement. Awake proning is offered to some of the patients. Hemodynamic support would be offered if there is hemodynamic instability. And a good ICU care is the hallmark, that is the benchmark, which really decides the outcome of this patient. A good ICU care is provided to these patients. The awake proning is given to patients who are not on ventilator, but where the persistent hypoxemia is there despite increasing supplemental oxygen requirement. But I would offer awake prone positioning only in stable patients. But if the patient requires immediate intubation and mechanical ventilation, then awake proning would not be advised. So awake proning would be advised in relatively stable patients because oxygen requirement is very high, who is comfortable while lying down prone, and he doesn't have any hemodynamic instability. In those patients, the awake proning would be advised. In some of the pregnant women also, we have tried awake prone positioning, and they're quite comfortable in doing that. They can be put into sideways position rather than absolute prone position. The high flow nasal cannula we prefer over the non-easy mechanical ventilation because most of these patients with hypoxemic respiratory failure is hardly now, the hypercapnic respiratory failure, and they tolerate the HFNC better. And the studies have shown that HFNC is effective, easy to apply, and better tolerated as compared to NIV. We prefer NIV, but if the patient got hypercapnic respiratory failure, especially those who are obese, those who got obesity, hypoventilation, and COPD, but otherwise we prefer using more HFNC. In selected cases where HFNC is not working, we prefer using the CPAP, where CPAP, is not a ventilator. It just improves the terminal airway. So we can offer a high CPAP, say, to the tune of 10 centimeter or 12 centimeter along with oxygen. So that is something that we do offer in some of these patients. The RDS management protocol would be the standard protocol where we offer a protective mechanical ventilation, relatively high P, but we have to be mindful that these patients can develop barotrauma. So we would like to be very judicious about using a P and try to be as appropriate as possible. Prone position has been found to be quite effective in these patients as compared to the patients of ARDS due to other causes. And we do offer prone position ventilation. Many of those cases, especially the FPF ratio is less than 100 millimeter of mercury. Antibiotics, according to culture sensitivity and the suspect is good to offer to this patient. And we generally avoid doing bronchoscopy and aerosolization in this patient to prevent the spread of infection. The pharmaceutical treatment for COVID infections include the repurposed drugs. Repurposed drugs are those which are indicated for other diseases, but have been commonly drugged when they talk about is chloroquine and hydroxychloroquine. The chloroquine and hydroxychloroquine is included in the Indian guidelines by the Ministry of Health of India. And but what we receive are not very effective, but still in India, a large number of patients are being treated and prophylaxis with hydroxychloroquine. The lopinavir ritonavir was used in the earlier part of the pandemic when the newer the investigation drugs were not available drug interactions. What we are more interested nowadays is the investigation drugs, the remdesivir and favipiravir. And as I said, we prefer more of remdesivir, especially the moderate cases or those who had a less moderate severe disease. The other inductive therapies are the corticosteroids and anti-cytokine therapy like tocilizumab we do offer in selected group patients. Now, thrombosis is extremely important to consider in this patient because thrombosis is the end point of the pathophysiology of these patients. And it has been observed that both arterial and venous thrombosis occurs in these patients. The arterial thrombosis has been observed in 2 to 6% of patients, and venous thrombosis has been observed in up to 31% of patients and 69% of patients with surveillance. And the French studies, the Italian studies have shown that even though the patients have been on prophylactic anticoagulants, they have developed thromboembolic events. So that's why thrombosis, the management of thrombosis and the use of anticoagulation therapy is the key in the management of moderately severe and severe cases of COVID infection. So how would you suspect pulmonary thromboembolism? If the D-dimer is passing more than 3000 or it's more than 6 times the upper limit of the D-dimer value that is there in your tube, the respiratory failure which is not justified by the radiological abnormalities, patients has got elevated biomarkers of acute right heart overload like anti-proBNP troponins, and the electrocardiographic findings like RA strain, the RV dilatation, they are quite suggestive of thromboembolism. Many of these patients may not be fit for going the CT angio, but if the patients got these kind of findings, I would rather try to treat them with therapeutic dose of anticoagulation rather than prophylactic doses. You can also do the high risk assessment of the thromboembolism by the Padua scale, which is easily available on the net and the mobile phones. And the Padua scale of more than 5 is suggestive of high risk of thromboembolism. So coming to the VTA prophylaxis in non-ICU patients, we routinely offer the standard prophylactic dose, but we consider intermediate or therapeutic dose in patients who are high risk, where the Padua score is equal to more than 4. And if the elevated D-dimer levels are more than 6 times of upper limit of normal, along with elevated CRP and troponins, then we would offer mostly the therapeutic dose. So we are quite liberal in using therapeutic doses of the anticoagulants in these patients. This is a protocol from Western Hospital which shows that they use in ICU the therapeutic doses of enoxaparin 40 milligrams BD, right? And if those patients where the creatinine clearance is there, they use unfractionated heparin of 7,500 units 8 hourly. And we prefer using more of LNWH as over the unfractionated heparin while managing these patients because of ease of administration and lack of requirement of repeated monitoring of the APTT. Dexamethasone has been strongly recommended by NIH guidelines in 2020, especially the patients who are on mechanical ventilation, and also in patients who are not on mechanical ventilation but are requiring supplemental oxygenation. And you can give a dose of 6 milligrams per day for up to 10 days. But please do not consider dexamethasone in patients who do not require oxygen. This is a strong recommendation. Do not use dexamethasone in patients who do not require oxygen because this could be associated with increased mortality and morbidity in these patients. Coming to investigation therapies, the data about these investigative therapies is quite limited. And on the other hand, the availability of these therapies is also quite limited in the country at the moment. But we do offer investigation therapies in some of these patients. And what we generally use as investigation therapy is the use of remdesivir, the convalescent plasma, and tocilizumab. Coming to remdesivir, it is indicated by the NIH, very strong recommendation, A1 recommendation. The patient were hospitalized about a moderate or severe disease with SpO2 less than 94% of room air, and those who require supplement oxygen. But remdesivir would be contraindicated if there is, transaminases which are more than 5 times the upper limit of normal. Those who have a severe renal impairment with eGFR less than 30, in pregnancy in children less than 12 years of age. The dose of remdesivir that we use is 200 mg IV on day 1, followed by 100 mg IV daily for 5 days. So the total dose of the remdesivir that we use is for 5 days. Tocilizumab is the anti-cytokine monoclonal antibodies which acts against the IL-6 receptors, and this would be considered in patients who got a moderate or severe disease where the oxygen requirement is increasing and the patient who are on mechanical ventilation, and those who are not improving despite the use of corticosteroids, and in those where the inflammatory markers like CRP, ferritin, and beta and IL-6 are high. In those cases, we do use tocilizumab, but there is a caveat here. If the patient got super active infection, bacterial infection, fungal infection, or if there is a possibility that the patient could be having underlying tuberculosis, then please do not use tocilizumab because it can, reduce the immunity of the patient. Then we can then land up with severe bacterial super infection and the activation of tuberculosis in these cases. So only when the infection is ruled out, the inflammatory markers are high, and the patient who is not responding to standard of care despite using the steroids, then only we use tocilizumab. And in Chinese study was found with the use of tocilizumab in 21 patients, there was reduction in the CRP, which is the inflammatory marker, there was a reduction in the temperature, there was decrease in the oxygen requirement of these patients, and improvement in the oxygen saturation. So it has been found to be, quite useful in small case series and the studies. Coming to convalescent plasma, the NIH says that although it is promising, it has not yet been shown to be safe and effective as a treatment of COVID-19 infections. This is the standpoint of NIH. But in India, convalescent plasma therapy is very, very popular, and it's quite well promoted by the government of India and the health authorities because of plasma banks here. And the attendants of patients just ask the first question as soon as we get a patient of the COVID infection, when to start the plasma therapy. So we do use plasma therapy quite commonly in moderately severe disease who are not improving after the use of the steroids. And as far as FDA-approved trials are concerned, the plasma therapy would be indicated if the patient has severe or immediately life-threatening disease, like those patients who are shocked in ARDS. So what I have learned over 6 months is that get ready and increase your surge ICU and hospital capacity. We got the first case of COVID in March 2020, but we started preparing ourselves from January itself. We created the negative pressure areas, the ICUs, the rooms, the wards. The engineering work was done. We started training ourselves in managing these patients. The nurses were trained, the clinicians were trained. We tried to acquire as much as knowledge from the international publications. Second point is to work on containment in the community and the hospital. The hospital, in fact, is a hotspot where the infection can really spread. In one instance, 10 of my ICU sisters and 2 of the ICU doctors got infected, which is a huge loss. So the stringent infection protection control measures have to be followed in hospital. Third is do not work in silos, work as a team. There has to be close coordination and cooperation between the administrators of the hospital and the clinicians. And the clinicians themselves have to form sort of a team. And the teamwork is required. One cannot shoulder this problem individually. PPE training is must, and right from the person who is the reception, the secretariat staff, the GDAs, the nursing staff, medical staff, paramedics, they must all be trained in PPE, and they must be donning the PPE appropriately, very importantly, appropriately throughout the hospital stay. Home care management of mild cases is recommended. That will reduce the healthcare burden, and this is what we are offering to most of our patients. Supportive and symptomatic care is the key. And this is the most important aspect of the management. Supportive and symptomatic care. Rest all is investigational. But supportive and respiratory care is the key, and there is no confusion, there is no doubt about it. That is the key in the management of these patients. Good symptomatic care, good supportive care, good ICU care is the bottom line in the management of these patients. Thrombotic complications are common. So antithrombotic therapy, use of anticoagulants is extremely important in these patients. Steroids decrease mortality in those requiring oxygen supplementation. Steroids have been found to be more useful in patients who are on mechanical ventilation as compared to those on moderate disease. So do not use steroids in the mild disease, but use in especially those who are on mechanical ventilation and those who have got a moderate disease. Remdesivir, on the other hand, is more useful in moderate severe disease as compared to those who have got a severe disease or those who are on mechanical ventilation. Many drugs are available, starting from colchicine to ivermectin to BCG, even statins. But At the moment, it appears that all the drugs are effective in COVID, but there is a very little evidence. So we should be very much careful in choosing a particular drug. The dictum is please do not do harm, because all these drugs, all these therapies can be having serious side effects. Thank you very much for your patient hearing.
Thank you, Dr. Manoj, for your informative talk. Yes, I believe that there will be a number of questions that will be raised by our audience, as well as some points for discussion by our panel members. First, I had one question that was sent by Professor Suong, and while Dr. Ashok Ratan already addressed a little bit of it, I would still like the other audience to share about this knowledge. So, Professor Ashok Ratan can just explain a little bit about what his answer was. The question is that which antibody test do you use in India for mass screening against spike S or against nucleocapsid N? Professor Ratan, could you just elaborate on it?
Yes, sir. As I mentioned, that you want to find out in two stages whether a person has been exposed, and if positive, then are you protected? The virus is novel, and none of us have cross-reacting antibodies. So none of us should be positive unless we have had asymptomatic exposure to the virus. So what is to be used is the most sensitive test, and that sensitive test is to antibodies against the nucleocapsid protein, which is abundant in the virus and most immunogenic, and all types of proteins, all types of antibodies. So the nucleocapsid antibodies, pan antibodies, this is available from Roche, which is very cost effective, and it is on chemiluminescence. So if it is positive, then you should test whether you have protective antibodies. If it is negative, it means that a person has not been exposed to the virus and that means is susceptible. And that is what many persons are using. In between, they had started using ELISA, but ELISA is, if the load is high, then you don't want to use ELISA. You want to use chemiluminescence, which is a closed system, which is automated and give you results in 18 minutes time or so.
Professor Dorothy is the chief of our laboratory side, might have some follow-up discussions. Professor Dorothy.
Professors, very knowledgeable information that we gained from your presentations. So I would like to know that yes, that of course, yes, you said the e-CLIA of the CLIA, it is the much more effective and the more valuable informative than ELISA. So in this regard, so what kind of the test would you like to recommend if we use the antibody serology test complementing the existing RT-PCR in case of the detection of the immunity in the healthcare workers, as well as the further prospecting of the possible convalescent plasma? So what kind of the the e-CLIA test, like the pan antigen test by the Roche ELISA system, or spike antigens like biodiaspora? So what kind of the brands would you like to recommendations out of the conflict of the interest? Can you recommend that?
See, as I said, for mass testing, you want to know whether there is exposure. For finding out whether you have protection, the protection is provided by spike protein. So any of the chemiluminescence tests, electrochemiluminescence test, which is against spike, that is by disorin or by, it's available by disorin, now also available by other methods. But the best is the spike protein that you want to test.
So in supposing that like a Roche diagnostics, it is the by ELISIS, it is the PAN antibody test. So the instead of the urine for the possible convalescent plasma, if because we cannot the neutralizing antibody testings because we don't have the too much BSL-3 facility yet. So instead in these areas, the PAN antibody or specific S antibody, which one it is the most valuable to use in the convalescent plasma?
For convalescent, you want spike protein.
Spike
and they have said that the dose, because it gives you semi-quantitative, and it should be, the spike protein should be more than, the titer should be more than 80 arbitrary unit per ml. That will be equivalent to 160 neutralizing doses for the PRNT test, which others have done wherever it is possible with BSL-3 facility. So for convalescent serum, you should look at spike protein and aiming at anybody having titer more than 80.
So, Professor Ashok, so in your PowerPoint, I noted that it is a rapid diagnostic test of the antigen. In case if the patient is asymptomatic and rapid antigen test found out to be the positive, you don't need to do the further testing. What does it mean? Because a rapid diagnostic test by antigen positive is asymptomatic, so it is confident enough, no need to do testing. Is it really pretty sure that it is the confirmed cases by rapid antigen testing?
In this SARS-CoV-2, the problem has been that majority of patients are asymptomatic. And while they are asymptomatic, they are transmitting the disease. So that is why in SARS, when it occurred in 2002, only symptomatic patients would be transmitting the infection. So when you isolated symptomatic patients, you stopped the transmission. In COVID-2, asymptomatic as well as pre-symptomatic are both transmitting infection. So in your case, because at the moment you have only a few samples, few patients, the best is to use an antigen test, and immediately after you get positive, the person should be isolated for 14 days. Once you isolate for 14 days, then he is not able to transmit infection to others. This virus is highly infectious. Only 10 minutes of face-to-face talk can cause infection. So that is why wherever possible, we should be wearing mask. Wherever possible, we should maintain a distance of at least 2 meters. Of course, now they say it is spread even by the air. So since it is spread in the air, even 2 meters is not enough. That would mean that whenever you are in public, you must wear mask, which will protect you as well as protect the environment. But rapid test is useful in the sense that it is very specific. So if it is positive, that means the patient is suffering, the asymptomatic or symptomatic is infected with this virus. If it is negative, we cannot be sure. So if you want to be sure, then you have to do RT-PCR, but RT-PCR even in India is taking 48 hours to, even though there are now 1400 labs. In January, there was one lab which was doing RT-PCR for COVID. At this moment, there are 1400 labs which are doing RT-PCR, and lakhs of tests are being done. But the turnaround time is 24 hours to 48 hours time. While in antigen detection, which is not the ideal test, you will get results in 20 minutes time, so you can isolate the person. So they also suggest that if you suspect the person is suffering from COVID infection and the test is negative, the antigen test is negative, then do keep the person in isolation and test after 1 day or 2 days, then the virus would have become higher, so it will be detected.
Thank you, Professor Shah, for all this discussion. There's a practical question that's been asked probably from Myanmar Express as well as Indian Express might be able to answer is, are these tests available in Myanmar, or are these tests available, widely available? Are these tests available in Myanmar?
Rapid antigen test.
Yes.
Yes, rapid antigen test is, as the professor showed in the PowerPoint, like the SB BioLine. It is initially they introduced into the country, but no FDA it is allowed to the coming into this kind of the rapid test. So only RT-PCR it is the only endorsed diagnostic test kits endorsed by the FDA. Yes, that is now.
What about antibody tests?
Antibody is still we are trying. Antibody it is the first antibody companies coming into the country. It is a Roche diagnostic test by an ELISA system. This is an electroclear system. It is a quite very much a satisfactory test, and so now they have to plan to donate the 6,000 tests. So that this is the current situation of the country. Yeah. Thank you very much.
Thank you. I think yes, Professor Vibra might want to join in and have some points of discussion. Please.
We cannot do the neutralizing antibody test at the moment. What we have at the moment is this Roche IgG determination, the ELISA system. So the question is there a correlation between this Roche IgG and neutralizing antibodies? Because we want to select donors for convalescent plasma, and since we cannot do the neutralizing antibody titer as yet, can we use the Roche test with a certain level of titer?
So the company has shared, to be fair, the company has shared information done in Finland that high titers against nuclear protein will also have spike. But ultimately it is a correlation which is not evidence based, but yes, some evidence is available. So ideally you would like to test against spike, but if it is the Roche antibodies that you have, then please select plasma which is after 3 weeks of the patient recovering and of high titer. The trouble is that Roche gives you only more than 1 and less than 1. It doesn't give you, you see, we have gone in for both Roche and Disorin, because Disorin gives you arbitrarily unit per ml. And if a person has more than 15, then a person is positive. And you have to have 80 units to be to have good immunity.
So with the Roche system, can you use this COI figures that comes out from the test?
Sir, I have no experience directly with this because we use only as 1 and less than 1. But I guess the results will be there. So we should look at the raw data and then see whether it correlates with protection. Because we have to attack with whatever is available with us and make the best use of whatever is available.
Thank you.
Yes, so, are there any points that might be discussed? Yes, also Musa. Yes, Professor Musa, please.
Professor, thank you for your valuable information. My name is Momo San from the South Lava designated hospitals for COVID-19. And in Myanmar, we practice that for the DC criteria, discharge criteria, the patient should be free of symptoms and improving the radiological sign and then 2 consecutive negative tests for RT-PCR in 48 hours apart. I would like to know, in your country, more and more patients are admitted to hospital and then isolated at home for the mild cases. What are the release of isolation if patient is isolated in the home, or if patient is admitted to the hospital, what are the discharge criteria?
Right. Initially what you said, there are a number of questions. So I'll first start off the patient who is admitted in the hospital and how to discharge. Then I'll talk about the home quarantine. So first thing is, initially we used to follow the same principle, same method as you were saying. The patient has to be asymptomatic in the hospital for at least 10 days and 2 RT-PCR negative. But according to latest CDC guidelines, according to latest Ministry of Health guidelines, we do not test, the repeat test we do not do in moderately severe patients before discharge. The patient has to be in the hospital for 10 days from the onset of the date of symptom, and he should be symptom free for at least 24 hours, that is free of fever, and there should be a stable respiratory status or improving respiratory status. So this patient can discharge after 10 days from the hospital, from the onset of the symptom, from the date of the onset of the symptom, without doing a RT-PCR test in this patient. So there is no need to do a double test at 48 hours time and then send them home, because we found, the patients used to become absolutely fine. They were eating well. They didn't require an oxygen, supplementation. And still, because the tests were coming out to be positive, they were hooked onto the hospital, which was very painful for the family as well, and also for the patient. That would also add to the cost to the treatment. So this is no more being followed, and this is what the CDC is doing. This is what we in India are also doing. So after 10 days, they are discharged from the hospital. But at the time of discharge, we ask them to go for self-quarantine for at least 7 days, right? So that is for those patients who have a moderately severe disease. But when we come to the severe disease, those who are admitted with oxygen saturation less than 90%, we know in these patients, the recovery time could be long. And these patients are immunocompromised. So they may be harboring the viral load much longer as compared to people who have a mild disease or moderate disease. So in these patients, as a discharge criteria, again, minimum 10 days from the date of onset of symptom, symptom-free for at least 24 hours, stable respiratory status. But in these cases, we do 1 RT-PCR test, which should be negative. So once their test is negative, in severe cases, after 10 days of onset of symptom, who are stable, then we can discharge this patient. And again, as a policy, they have to be in self-isolation, home quarantine for 7 days after discharge. Coming to the patients who are the contacts of COVID positive patients who don't have any symptoms, then in those patients, we ask them to go for self-quarantine for 17 days after their last exposure, after their last date of exposure to a patient to whom they have come in contact. So for asymptomatic patients, we ask them, those who are found to be negative, we keep them quarantined for 17 days as of now, right? Now, home isolation practices are that the patient has to live in a separate room with attached toilet. He has to use separate utensils. He has to wear the mask, surgical mask, whenever some care is being provided to him. There should be one person designated to take care of himself, who should be healthy, right? Who should not be vulnerable, who should not be having any comorbidities, right? And then when he is, caring of these patients, then try to maintain at least, distance of 2 meters or 6 feet, as we have advised, and wear the mask. Surgical mask is advised, this should be. And the person has to, the person who is infected has to dispose of his things on his own, take care of himself, has to, take care of his, vital charting, the symptoms, the respiratory rate, the pulse oximetry. So those things have to be done, by him on his own, and he has to report it to the family members and the health authorities time to time. The other thing is, those who are vulnerable in the family, like elderly people, more than 60 years, they have to be absolutely separated from the person who is infected. He is absolutely not allowed. He should not be allowed to come in contact with this patient. He should not come in the care of this patient. So these are the usual, home care advice that we give to these patients.
Thank you, Professor. I have one question. And in our country, most of the patients what we isolate in our hospital is asymptomatic. 40 to 60% of the patients are asymptomatic, and they are the contact. We found that patient because of the contact tracing, and then recently we tested the COVID-19 and found positive, and we isolate in the hospital. these asymptomatic patients, they have a symptom during the hospital stay, like a 9 or 10 day or 2 weeks time. At that point, what we should do, but in our country, we tested 2 negative is a discharge criteria. According to your discharge criteria, what should we do? Because symptoms appear during the hospital stay after 2 weeks.
First of all, it is highly unusual. The incubation period can be from 2 days to 14 days. I've already said about it, but usually the incubation period is 5 to 6 days. And at the day of the symptom, the patient has got the highest viral load, and that is time he is excreting the virus to the maximum. And this virus excretion goes on for maybe up to a week after the patient has the first symptom. So the maximum viral load is observed in the pre-symptomatic phase and the first week after the patient becomes symptomatic. The peak is viral load is on the day when the patient got his first symptom. So that is the usual turn. So what you're talking to me is highly unusual. When a patient develops a fever after 2 weeks of getting diagnosed, in those cases we should look for other causes of fever in this patient, whether this patient got some UTI or other bacterial infection or something. But this is highly unusual. But still, if you think the patient has developed symptom after 12 days or 14 days after COVID positive, then this patient again will fall into the criteria where patient has to be kept in the hospital for at least 10 days from the onset of symptoms, right? And as per the guidelines of your country, you have to follow that if this patient becomes negative twice at 48 hours, and then only can be discharged. But I think I would request you to raise this thing with your authorities, because this is no more valid. It is practically no more done in other parts of the world. The retesting and keeping the asymptomatic patients at home, that is something is not usually practiced. So mild cases, asymptomatic cases have to be managed at home only most of the time, until unless there is no one to take care of them, or until unless somebody who is very is in greater risk, vulnerable person who is in a greater risk of acquiring infection and having high mortality. So though it's apart from those exceptions, it's better to manage these patients at home.
Can I add something to it? See, it was WHO, CDC, and Government of India. All three have changed the discharge criteria for testing to symptoms now. So initially, it was noticed that the virus is excreted for the first 8 days. Thereafter, RT-PCR may be positive for weeks together, but the virus is no longer infectious to the cell lines. So they decided that instead of being wasteful to the resources by doing repeated testing and getting positive results, it's best that the person should be asymptomatic before, at least for 3 days before you discharge him.
Thank you. Yes. Yes.
I can add further to it. Yes. Because that I agree with Professor that initially again it has not been changed. The recent guidelines, if you look at the CDC, they now say 24 hours, not 3 days. So we came from that phase where the patient had to be negative for twice, right? Then we followed this advice of 3 days of asymptomatic period without testing discharge. Now we are discharging patients with 24 hours of asymptomatic phase without test. So I mean things are progressing that way.
Thank you. We are right in the middle of some lot of clinical discussions. There's a lot of clinicians in the room, but I have also some burning questions that are being sent to me from the audience, and I would like to share one question since we are still in the midst of clinical discussions. It's from a pulmonologist in Myanmar, and the question is that concerning with the incidence of fibrotic consequence in patients who survive COVID-19 ARDS. Question is, what is the incidence of fibrotic consequence in patients who survive ARDS, and is there any role of antifibrotic therapy for those patients? People people in our group as well as Dr. Mehta might like to answer. Maybe Dr. Mehta first, please.
Right. So, we have learned that it's a highly inflammatory disease. I mean, more than the virus, it is the inflammation that it creates in the body that causes the damage, and the lungs are really affected. So the patients who got a moderate disease or severe disease, who got extensive involvement, there is intense inflammation, and this inflammation would, heal by doing fibrosis. So most of the patients who have developed a severe bilateral pneumonia would end up with severe, some sort of fibrosis. And that's why, after discharge of these patients, we generally, in severe cases, we like to do a chest X-ray and look for their oxygen saturation. If the oxygen saturation still continues to be, say, around 94%, 90%, we'd like to do a CT scan in this patient, see how much is the degree of inflammation, how much is the degree of fibrosis in this patient. So in these patients, what we do, we put them on long-term corticosteroids, which may vary from 1 month to 2 months. All right, because the anti-inflammatory drug in these cases would ideally be cortisone, and the cortisone that we use is a methylprednisolone. Here we do not use dexamethasone, because dexamethasone we use during the early part of this disease when it is very active. But here we use the methylprednisolone, which the dose may vary from 32 milligram to 40 milligram, and then we taper it off over a period of time depending on what the progress of the patient is. Accordingly, they go into pulmonary rehabilitation program where they are told to do certain breathing exercises, the physical exercises. So this is something they are told about it. So definitely this is one aspect, especially those who got a severe disease and moderate disease, which is more towards the severe. We really have to follow these patients carefully, radiologically, clinically, pulse oximetry wise, their effort tolerance wise, how much the walking distance these patients having in their day-to-day activity. And then that can be treated only by giving steroids, and they work. As the antifibrotic drugs are concerned, a couple of trials have been published, but the role of antifibrotic drugs in these cases is very, very dubious and not established. And as of now, it is not recommended to use the antifibrotic, because if you talk about the antifibrotic, they have a long-term effect. If you start antifibrotic drug now, the effect will start maybe after 3 months or 6 months. But here we want an acute amelioration of the inflammatory process, and that can be done only with the use of the steroids. So the steroids become the key in the recovery phase of these patients to prevent the fibrosis. But presently, no antifibrotics are to be used.
Thank you, Professor. There's Professor Swade, who is one of our panel members, who would like to join this session. Before Professor Swade starts the discussion, I'd like to remind the audience that some people are raising their hands. I believe they want to join the discussion, but since it's a webinar, there's also a chat box as well as a Q&A box, and I would rather prefer them to be asking their questions to the Q&A box, which will make things more organized. So, yes, Professor Dosway, please.
Thank you, Dr. Manoj. We have very excellent presentations. And regarding the choreography, I want to know we have to be recurrent of this raised T-timer after the treatment for the 5 to 10 days of pain happening. After that, maybe during the positive SWOT period, we have to be the recurrent of the raising of the T-timer level. So this is part of your experience for the recurrent raising of the T-timer level. Is there any long-term or anticoagulants treatments for the nearly 1 month after the T-timer level is raising again and again? They say the most problem this is in organ transplant patients. So maybe please share me for the anticoagulant therapy for the choreography. Thank you.
Again, a very excellent question and controversial, and the people are working a lot on this question. And to be very honest, I use the therapeutic doses of anticoagulants in the treatment of these cases, particularly those who have a severe disease. I try more to use the therapeutic dose until unless there is a contraindication. In moderate disease, I would use a prophylactic dose, but again, if the high-risk patient is there, then I would again use the intermediate dose or therapeutic dose. Intermediate dose is the one which is 50% higher than the prophylactic dose. So this is, I would do definitely in all the patients, and I'm quite liberal in using therapeutic doses of anticoagulation, especially in severe cases. The risk factor or no risk factor, I would try to use more of a therapeutic dose until there is a contraindication. Now coming to the discharge time, what to do in these patients. Now at the time of discharge, I do a D-dimer in these patients. If the D-dimer level is more than 2 times the normal upper limit, then I would continue the anticoagulation as a prophylactic dose at least, until I am really suspecting there is a pulmonary embolism in these patients. Okay? So I would continue with prophylactic dose, and the drug that we use that I generally use personally is rivaroxaban, and I do a prophylactic dose of 15 milligram in these patients, 10 to 15 milligram. And then I'll follow these patients after 15 days and call them back with D-dimer, and they look for their symptoms. If the D-dimer continues to be high, then I'll continue with the anticoagulation, prophylactic anticoagulant, that is rivaroxaban, with a dose of 15 to 10 milligram, till the D-dimer becomes normal and oxygen saturation becomes normal. So I would continue for at least waiting from 15 days to 1 to 2 months the prophylactic anticoagulant in these cases, because these patients are also at high risk of developing pulmonary embolism later for part of the disease during the recovery phase also. So high risk patients where the D-dimer is more than 24, definitely I will discharge them with a prophylactic anticoagulant, and my choice would be the rivaroxaban, varying from 15 milligram to 10 milligram per day.
Thank you.
Thank you. I want to know you do have any experience of the flavivir or Avigan? They have to be the very high dose for the 10 mg for 1 day and another 10 tablets for the 4 days. Is there any experience for the Avigan for our COVID patients for the mitochondrial basis?
So favipiravir has been approved as an emergency use in India. But again, whenever we use favipiravir, we have to report it to the authorities so that they collect the data of what is happening in these patients. To be very honest, I'm not a great fan of favipiravir. They recommend in mild cases, asymptomatic cases. I generally don't use any antiviral treatment. Any of the mild cases with oxygen saturation more than 95%, the chest X is normal, just keep them in symptomatic treatment. I don't offer any of the antiviral or repurposed drug, hydroxychloroquine, I don't offer them at all. But those who are a moderate disease and those who require oxygen saturation, oxygen requirement of say up to 2 liters, right? And who do not have extensive lung involvement or chest X CT scan, and those who do not have the comorbidities, in those select cases, I do use favipiravir, right? But then again, I have to tell them about the side effects of these patients. Somebody who's got a hepatorenal problems, deranged KFTs, deranged LFTs, then again, this is not indicated. It can be transmitted in the secretions, the semen. So there has to be abstinence for at least after 1 month after stopping this drug. So that is again a problem. So that has to be explained to the family. The pregnant women, it has not to be given. So generally, I think favipiravir, the data is very much limited. As a rapid, need, this has been recommended. I feel that mild cases you use antiviral or no antiviral, it's not going to make any difference. But in moderate cases where I'm little reluctant using remdesivir, then in early cases, maybe up to 2 liters of oxygen required, I would use favipiravir and see what happens. But many of these patients who progress, I stop favipiravir and then go on to start remdesivir in these cases.
Yes, thank you, Robs. Thank you for all the discussions. There are all sorts of questions coming along. One question is that about addressed to Dr. Goel, and it's about the ACE inhibitors. The question is that in one of your slides you mentioned ACE inhibitors, and the person who asked about the question is that he's referring to one study in China which says that maybe they are not that good and even detrimental. So would like to respond to that?
Yes. So the thing is, this started off, right from the beginning that, using ACE inhibitors may allow more entry of the, virus into the system, into the cellular levels in the human beings. But it has not been proven substantially. And in fact, all the cardiology societies, they suggest if the ACE inhibitors are required to be given, then they have to be given in the care of that patient. So we do not stop ACE inhibitors. If they're recommended or they're advised during the course of the treatment, we do offer them and we continue with them. So presently, there is no strong data to suggest that using the ACE inhibitors is going to increase the viral load or cause increased morbidity. So we continue with ACE inhibitors. We don't stop it.
Yes, thank you. Is there any points from our, yes, Professor, our TTA team seems to be willing to join in with our discussion, so I'll ask you to invite Professor TTA to.
Yes, I would like to ask one short question to the professor. in your slide that you did not mention about loop-mediated isothermal applications, LAMP methodology. It is quite simple and sweet, and also it is based on the RT-PCR. So, can you share some experience that who are in the Indian experience working out with the LAMP? Because nowadays we have the some proposals to the submitted to the Ministry of Health is whether we do something new technology, new platform, the not existing. So we have the real-time PCR, RT-PCR, and Cobalt 6800 fully automatic PCR, as well as the GenExpert. So that we are now considering seriously to install the new platform like a lab. So can you share some experience in India working with the lab? Thank you.
LAMP in India is available for tuberculosis, and that's why we were very keen that we should use, and because as you know, in LAMP you can get the results by naked eye rather than by using the instrument, and we were very keen that we should have a LAMP test, especially for far off places. But unfortunately, we have a project with the Department of Biotechnology for developing a LAMP test, but commercially the LAMP test is not yet available. But I think that is, if this pandemic lasts for longer than another month or so, then there would be many LAMP tests available. RT LAMP is, because it is isothermal and because the results can be read by naked eye, especially if it is by CRISPR, then it will be both cheaper and faster and available to be used in smaller hospitals which may or may not have the equipment. So I am all supportive of LAMP, but at the moment it is not commercially available. So for a diagnostic lab, it is difficult to do. Not available in India. I think there is one company in Ireland who has got it, and in South Korea also, as well as China, LAMP tests have been used.
Yes, yes, because the Japanese introduced the LAMP testing to the saliva in the third week of the July. So the currently the Japan counselor or the Japan ambassador, it is now sending the questions to me whether Myanmar can accept the travelers inbound into the country tested by the saliva's LAMP test. And now currently we don't have the testing protocol and that, so we deny that we don't allow those persons to be tested negative by the LAMP test. So that's why I'm asking you for the Indian experience. Thank you very much.
You might want to do in-house validation, because I have always, there was a study from Yale University which indicated that the viral load in saliva was consistent and persistent and better than nasopharyngeal. But somehow it has not found favor with health authorities in India. They have overlooked the study, and there has been nobody who's been able to confirm. I work in a commercial lab which does only work which has been approved by the government, so that we don't run into any trouble during this pandemic time. So we comply with all the requirements that are there, though we do keep reading the literature and pushing them to use saliva. If saliva is self-collected and then, or it is collected in viral transport medium, then there's no risk to anybody. So it would have saved the PPEs to be used by the clinicians rather than being used in the lab. But again, that has not found favor with the authorities, so they have not yet permitted that.
Thank you, Professor, for your discussions. While we are in the middle of laboratory diagnostic discussions, there's a question coming along about the specificity of the antigen test. The question is that, are there any possibility of false positive antigen tests? So probably both our panelists and also that they might want to discuss about that question. Maybe
Sir, in case of RT-PCR, because the fragment chosen has been tested against blast and they are specific and personal to SARS-CoV-2, specificity is not in doubt as far as RT-PCR is concerned. The sensitivity is in doubt because sensitivity depends upon the sample that you pick up and whether nasopharyngeal has been picked up correctly or not, and the time when it is picked up. If you pick up in the um, incubation period, RT-PCR may be negative, and if you pick up too late in infection, RT-PCR again may be negative. Same is case with antigen detection. The antigen detection is specific in two studies done by the government of India in All India Institute as well as conducted by them in Max Hospital. They found that antigen detection and RT-PCR matched nearly 100%. But antigen detection missed a number of RT-PCR positive cases. That could easily be explained on the basis that antigen is detecting pre-existing antigen load, while in RT-PCR we can amplify the presence of RNA, and so it can be more sensitive. Whether antigen detection is false positive, not many cases have come. One or two, in any case, it could be a technical fault rather than a biological fault. But more or less, antigen detection and RT-PCR agree with each other.
thank you, Mr. Ratan. This is a question that we more related with our MI experts, more operational side that I believe is that is Myanmar using gross antigen tests now, and how many years have you been?
No. Those rapid antigen tests in Myanmar practice currently there is no practice of doing the rapid antigen test yet. Only the Myanmar currently doing only the antigen testing by the robust real-time transcriptase real-time PCR only. So Ministry of Health and Sports doesn't allow to use either rapid antigen test or the rapid antibody test yet.
Thank you, sir. There are some more clinical questions coming up. One is that about the use of chloroquine in India. Are you still using it, and have you stopped using it? And there's another thing about the role of H2 antibodies, pembrolizumab in the management of COVID-19. Probably Dr. Goel might want to join in the discussion.
So still the Indian guidelines do recommend use of chloroquine and hydroxychloroquine in the management of COVID infection in those who have moderately severe disease. So that is, I think, in the government institutions rigidly being followed. It has also been advised as a prophylaxis for close contacts and healthcare professionals. And this is again in the government institutes, it's very well being followed. So I think the SCQS, I won't say even government institute, but rather in the private presently is going out of favor all over the world. FDA has already dropped it, NIH has already dropped it from the treatment protocol. But yes, in India, we are using it quite frequently. Personally, I am not using it personally. Of course, I'm part of the governance. But, these are the guidelines. They have not been put as a rule that it is a rule that has to be followed by each and everyone. So we have the liberty of using our clinical judgment. So we are more, either I'm not using SCQS or any antiviral, but if I'm using antiviral, my first choice would be remdesivir and second choice would be favipiravir. And one thing that I want to tell you about remdesivir is remdesivir does not improve the mortality outcome. There is no significant difference in the mortality outcome when you use remdesivir. What it does, it improves the recovery time. So that is the only advantage that remdesivir has. And favipiravir is still, the data is very early, and even in the phase 2 and phase 3 trial all over the world. So we really do not have data of strong data about favipiravir, but it has been found to be promising. So in selected cases, less severe disease, less moderate disease, I do use favipiravir. But SCQS personally I don't use. But in India, yes, it is being used quite extensively.
Thank you. There's another questions that been asked about the availability of the drugs. So I believe that since you're already using remdesivir is available in India. Is it generic? Are you using it? Or another is it about the tocilizumab? Is it also available in India, and are you using it? And what about in Nepal?
Yeah, so remdesivir and tocilizumab are available, but not freely available. But they are mostly available in the big cities, metro cities like Delhi, Mumbai, Bangalore. But in small cities, the level 2 cities, they're not easily available. Recently, we have again gone short of the tocilizumab because it has been extensively used by the medical fraternity in India. Maybe a little overused, I can say, where one could have avoided it. But yes, they are available. Presently in Delhi, the supply is adequate. But yes, in many parts of the country, it may not be available freely. So we have to definitely use in judiciously in selected cases. Tocilizumab can be very useful, I feel, if the patient definitely has got a cytokine storm. But yes, it can lead to superated infections and adverse outcome also. So one has to be mindful of that. It can cause thrombocytopenia. It can cause, raise in the LFTs. The transaminase may go up significantly. So, but my point of view is that, it can lead to secondary infections, reactivation tuberculosis. One of my patients landed with reactivation of tuberculosis. He had developed bilateral pleural effusion after treating with tocilizumab. So we have to be mindful of using, as I said, we have to identify what is the pathophysiological target we are using. So we have to assess the patient clinically and by using the biochemical parameters that we have, whether this patient is having a cytokine storm, whether he's got a secondary infection. Those are things that we have to identify and then use it. Similarly, you want to use remdesivir, you would like to use remdesivir in the first week of the onset of the disease. If you're using remdesivir in the second week or third week, it's not going to work because that is the time when you're trying to use the antiviral activity to inhibit the antiviral activity. So somebody who is coming to you with a history of fever 10 days coming to you and then using remdesivir may not be as useful. But yes, it has not been contraindicated. You can still use in those patients who are coming to pneumonia. As Madam said, somebody developed symptoms after 12 days of being positive. Those cases you can use remdesivir. But generally it will be more useful in the first week. Similarly, dexamethasone has been found to be more useful in the second week. Right? The recovery study that we talk about shows that dexamethasone use is more useful in the second week because that is the time when the inflammation is taking part. So first week you attack with remdesivir, second week you attack with dexamethasone. Similarly, convalescent plasma, within 10 days of the onset of symptom is the one where it is going to be more effective. If you're using convalescent plasma after 3 weeks of the onset of symptom patient who's got an inflammatory pneumonia, organizing pneumonia, who's got a secondary effect or bacterial infection, then you're using convalescent plasma is not going to be effective. One thing which you can use universally is the anticoagulants. Moderate disease, severe disease, at any time patient comes to you, please do use anticoagulants. That's very, very important. That is something which is not very controversial. And of course, what decides the outcome of these patients is good supportive care, good critical care, good supportive care, good care of nutrition, good organ support. These are the things which really decide the outcome of these patients. Rest all, I believe, remains investigational.
Thank you. Thank you, Professor. We had quite a very fruitful and lively discussion, but the time is rather short. I will just allow one more question, and the question is raised at initially, but of course the laboratory side also gets involved with it. So a little bit more generalized in the sense that what is the evidence of increased mortality underlying renal disorders? But then renal disorders means a lot of things, and stage of disease would be quite different. So it would be quite a challenging question to answer. But maybe, Professor, you might want to add something about it or answer about that. Manoj, please.
Sorry, I couldn't get the question. What was the question?
Yes, the mortality, increased mortality related to renal disorders. Patients with
increased mortality related to COVID? That
Yeah.
is the question.
Yeah.
Yeah. So as of now, if you look at the world chart, the mortality rate has come down significantly. Initially, March, what was happening when we were observing, we were talking about now the overall caseload and the mortality. We were looking at the outcome. So outcome means out of those patients who have reached the outcome, what has been the mortality rate? So outcome means patients either have recovered or those who have died. So of those patients, still there was, the case load of 20 lakh was there. We were observing mortality rate of 25%, to be very honest. Although every time it is 3% or 4%. But if you look at the total mortality of the outcome cases, final outcome cases, it used to be 25%. Now it has come down to 6%. So consistently, the mortality has been decreasing. Of course, the number of cases has been consistently increasing. But as a matter of fact, the mortality rate has been decreasing. And this is what is being observed in India also, right? And the reason for this is now we better understand the pathophysiology of these patients and we target the pathophysiological end points, the phenomena. And good critical care, good supportive care has really reduced the mortality of these patients. And of course, possibly the use of the investigational drugs like remdesivir, maybe plasma, maybe tocilizumab in selected cases has helped in improving the mortality outcome of these patients. So I do not agree in India, the mortality rate in fact is now 3% and in fact less than 3%. And we have a caseload around 25%. So 25 lakhs or more. So in fact, India, the mortality is almost similar to that we observed in China. It is not as it was there in Italy. And other reason is possibly in India, more of, younger generation is getting infected because elderly are keeping home. They do not go for job, their work. And that is the vulnerable population. So if I look at my local city, that is Gurgaon, I see more of the younger patients rather than patients who are elderly, who are coming to the hospital with this disease. But yes, those who are coming with in vulnerable group, elderly patients, cardiovascular diseases, heart diseases, diabetics, they're at higher risk. And there, I think the mortality remains the same. So if you ask me what has been my mortality rate in patients who have undergone a ventilatory support. So in that case, my mortality rate continues to be 45%, which is still quite significant and which almost matches the world literature. But otherwise, overall mortality has come down, is not much.
Thank you, Professor. Thank you, Professor Ashok Rattan. Thank you, Professor Manoj Kumar, and our panel members, Professor Vimra, Professor Totidiki, Professor Mumusa, Professor Subeju. We have all tried this webinar COVID-19 and Indian experience. I'm sure that everybody learned a lot of things from our webinar and everybody enjoyed it. But at the same time, we will hopeful that it will assist to a better care for our patients. So with these remarks, I would like to end our webinar. Thank you all for attending and all the attendees and the people who are trying to discuss. Thank you all.
Thank you. It has been a pleasure meeting you all and talking to us. We also had a learning experience and we look forward to seeing you even more in future. Thank you.
Thank you.
And I will be stopping the video and I'll stopping our office.
Thank you. Goodbye.
Bye.